So this is the next phase before delivery. Last visit, we took the occlusal record and impression of the soft tissue, and the laboratory and sequence sends us back a mock-up. It's a denture tooth mock-up, which is great, only utilizing 3 of the implants to make a quick try-in. They relieve the area where the other implants are, or the other multi-units are, so it'll fit right over top of those implants. So we're just going to try it in. We're going to confirm our occlusion. We're going to confirm the aesthetics and tooth position. And if everything looks good, then the laboratory is essentially just going to make a duplicate of this in the definitive material. So that's it.
Dr. Pacinelli, you mind bringing that more up to the camera for a second,
sure.
so the audience to show them what. Why don't they only do 3 implants on?
Well, because we've already confirmed. If you're looking for, I'll get down. See, if you're looking for cast confirmation, we already have that in our pickup and impression. This is soft tissue impression or registering the position of the implant. So this is the confirmation jig. And when you only are using 3, you get a tripod of stops, so you know it's fully seated, and it just makes it easier and quicker because you only have to screw in and screw out 3. That's the reason why. So again, it's only a tooth setup. It's only an occlusal confirmation. It's not a definitive restoration. This is in a plastic or like a resin and a wax. The teeth are set in wax, and so if we need to make any changes or adjustments, I can do that. And we're going to check that right now.
Okay, great. Thank you.
This is what you really want to see when you take off the provisional prosthesis. Where if you look at the tissue is level and it's even, and the pontic areas are really relatively flat. So you're not going to have a ridge lap after in your definitive prosthesis. And what we also see, which is great, and sometimes you don't always see this, is that the multi-unit platform is right at the gingival level, maybe a 0.5 millimeter or 1 millimeter subgingival, which is nice. So you don't have the collar of the multi-unit sticking out. And where that is also right in line with the soft tissue. So the prosthesis is going to be nice and hygienic when it's fabricated. So this is the soft tissue cast that we captured from the last soft tissue pickup impression and the occlusal registration. So essentially it's a back pour into our Duke prosthesis. If you recall, there was impression material that I squirted underneath of it, and then it was back poured onto this. And again, this is our now this becomes our master cast. This becomes our master cast that the prosthesis is going to be fabricated on. I know it doesn't look like a traditional cast, hard tissue or soft tissue cast, but that's what it's going to be. And again, this is the cast that this mock-up was fabricated on. And so this mock-up goes right to the tissue. And again, there's no ridge lap. And that's exactly what I'm talking about in what we want to see and what these immediate load cases provide us with. We allowed the prosthesis, the provisional prosthesis, to develop the soft tissue. And that's all accounted for in the pre-plan. So we're going to try this in. You all right? So he kind of flinched a little bit because it's pushing on the tissue a little bit, and you'll see that. And sometimes if it's uncomfortable, or when we deliver the definitive prosthesis, if it's too tight to the tissue, we may have to adjust the intaglio of the restoration so it's cleansable and the patient doesn't have discomfort on the soft tissue. So again, we want to screw all 3 in. Now just gently close down for me. Gently close, 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 close. Okay, good. Now I just want to confirm our occlusion. When you're biting down, do we have a articulate paper? When you're biting down, does it feel that your bite feels even, or do you feel like you're hitting on one side more than another?
Feels pretty even. It might be hitting a little on the left side.
Okay.
But it feels pretty even.
Okay. And bite down. And bite on your back teeth, Jack. Your back here, on your molars. Open for me. Just relax your jaw and bite down. Try and bite on the back here. Yeah, there we go. Perfect. You want to come and take a closer look at here? You still feel when you bite down, you feel like it's hitting a little bit on that side?
Yeah.
Okay. Open. And bite down here.
Oh, okay.
And open. And bite down. And open. And bite down. And open. Okay. And bite down again. Okay. And open. Okay. So what I'd like to do in this scenario is I'll just adjust it intraorally.
Now, does it matter what teeth they use to set?
Well, you're setting the teeth based off of the pre-op.
Okay, I'm saying the teeth that they actually have in here, these are the same material, the teeth that's going to be in.
No, these are denture teeth.
These are just denture.
And then what they'll do is they'll scan it,
Gotcha.
scan the entire prosthesis, and then they'll fabricate it off of it. And then we're going to take a bite. Okay. And bite down for a minute. Bite down. Don't feel high over there?
Much better.
Better. Right? So, I mean, minor adjustment. I mean, it's nothing. Nothing. Bite over here. Good. That's what I'm talking about. Okay. Another. And bite down. Now, again, I don't want to have a really deep bite on him. I don't want to have excessive vertical overlap. And so this is what we talked about at the beginning, and this is what we're talking about now. So, and bite down.
Yeah, if I remember, he did have his original setup.
It was like this.
Yeah, deep bite.
Yeah. And slide your teeth forward. Keep coming forward. And go side to side for me. Good. Okay. I know that a lot of people like a group function. A lot of people will say, put them in canine guidance. Canine guidance is more for convenience, in my opinion. It's easier to put somebody in canine guidance than it is to put somebody in group function. But when you're trying to distribute the force, I like to put somebody in group function. So, what we're going to do, I just want to take an occlusal reg. Perfect. All right. So, Jack, I'm just going to squirt some goo over your teeth, and you're just going to bite down for me, and bite down for me. Practice biting. Good. And open. Yeah. I advocate for a try-in because some practitioners will go straight from the duplicate prosthesis or and go right to the definitive restoration. I always need to do a try-in to confirm where we are and to have the patient sign off on it. So I like to always do a wax tooth try-in. And if you don't like the position of the teeth, or if our occlusion is slightly off, like we just saw right now with Jack, I can make an occlusal adjustment on the denture setup. If we're vastly off, if we don't like the midline, if it's canted, if there's anything that's off, the patient doesn't like it, all we got to do is take a hot spatula and move the teeth into position. Some practitioners don't like to do that. You could always take photos and take notes and relay that information to the lab so they can move the teeth in an appropriate position. But it's always wise to capture a new occlusal record or a new bite along with that appointment, so they can possibly remount it and reorient a couple of things to get a better outcome. So the good thing for Jack is that, again, we took our time to get the clear dupe mock-up in the right position, and our aesthetics are really, really tight, and our midline's on, and everything looks great, except for a minor occlusal adjustment. And that is standard because an articulator or a virtual articulator is never as accurate and dynamic as what a patient is able to recreate. So I always like to have a live try-in. And when we deliver it, we're still going to probably have to make a couple of occlusal adjustments, but that's normal. All right?
That's a nice mouth.
Yeah.
All right, so we're here for the delivery visit for Jack. The definitive prosthesis that was fabricated by InSequence was your milled peak bar with the nano ceramic teeth. It's a replication of the setup that we tried in at the last visit. And so inserting this prosthesis is basically just like trying in the mock-up prosthesis. And we'll take it from there. Again, everything is made off of the impression that we made after the implants had integrated. His existing provisional has sculpted the tissue, and as you can see, the intaglio of this prosthesis is very hygienic and easy for the patient to clean. So DJ, I took out all but the one screw.
It's funny, that's one of the main things I learned from you, is that front screw.
I will have the prosthesis, the interim prosthesis, clean, preserve every screw, and we will give it to the patient. Tell the patient to keep it in a safe place, in a safe or safety deposit box for whatever reason. Because if they have to have the definitive prosthesis service for whatever reason, it fractures, it breaks, they fall, there's an accident, at least we have a backup. And I like to have the patient carry it so I'm not responsible for it. Great about InSequence is that everything is delivered just like the surgical guides and all the parts and components from the surgery till now. Here, this is delivered, it's in a sealed container of the final screws. I like to call them definitive screws. I like to call this definitive prosthesis because, you know, you don't like to say anything is really final. But these screws are virgin screws, never been used on the cast and in the lab. The lab are using lab screws, so you're not fatiguing the screws when you're working on the prosthesis. So then when I put this in, I will tripod the screws and I'll tighten those 3 screws like I'm tightening a tire on a car. I don't really crank down on them until I have everything engaged, and then I'll put the other screws in, and then I'll go again, and then I'll torque it down as if I was tightening a car tire. I want to make sure that I dial in any adjustments first, and if I have to remove it, it'll just make it easier so I don't have to take out all of the screws. So I'll tripod the screws, try it in, and now I'm going to check the occlusion. All right. Now the aesthetics should be on. So you know, if you want to swap for me. So I'm hurting him a little bit because it's putting a little pressure on his gingiva. So we're going to see. So Jack, when you bite down, I haven't checked your bite at all with my articulating paper, but does it feel like you're hitting on both sides?
Yes, it does.
Okay.
Feels good.
And bite down for me. And open. Great. And bite down for me. Great. And open. And bite down for me. Great. And open. And bite down for me. Great. And open. Okay. Good. And bite down for me. Beautiful. And open. And bite down for me. Great. And open. And bite down for me. Great. And open. Okay, good. And bite down again. Beautiful. Beautiful, beautiful, beautiful. All right. Does it feel a little tight up here?
A little bit.
A little bit. So if you notice here.
It's blanching.
Yes, this tissue is blanching in the anterior. If you're getting a little blanching, I would prefer to monitor that, to be honest with you.
Okay. Like take down on the base a little?
Yes. Exactly.
What do you usually do that with? Just
I'll use an acrylic burr for this. Just use an acrylic burr, and then I'll put it on my wheel. So what I'll normally do is I would take like a floss. I'm doing it with basically a probe. I'm feeling if there's just a little bit of room to bite that one. So I'm going to take it out. I mean, I'm going to make some adjustments, and if bite down again, honey. So now what I'll do is I'll just take like a pencil. It's tight. Open for me. So if you've screwed in all 5 screws, then I have to unscrew all 5 screws.
It's annoying.
You see? Yeah. I got it. You see it?
unblenched.
Yes.
So the second he took it off, the color came back. You know what I'm saying?
Yeah. All right. Still, can you move that light for me?
Yeah.
Just maybe right here in the end, just right here in the middle.
Yeah, right in the anterior.
Yeah. So this is really nice material. This nano ceramic is really nice for proposing natural teeth. If you're posing porcelain, this is going to lose. It's going to take time. It's going to take time. But when Jack does his lower,
Hey. I heard
you're
you.
going to use this material. This is the material you're going to use.
Okay.
You know?
So you would use this, for example, on natural teeth on the opposing arch, non-Bruxer.
Yes.
Would be a great
Yeah.
person. Great candidate.
I mean, it's beautiful. I mean, it
Even
looks,
like
looks
someone
nice.
was wearing a denture on the lower.
Yeah.
It'd be totally fine.
Yeah, exactly.
But a Bruxer with low bridge work or Bruxer.
I mean, the bridge,
zirconium. Well, zirconium against this you wouldn't do.
well, the zirconium is going to wear this more than anything.
Right.
I mean, it's putting light pressure on the tissue where a whole bunch of stuff's not going to get accumulating, and that they could get either a floss or a floss threader or something called a super floss underneath it to clean. If you leave too much of a space, sometimes the patient, obviously they might accumulate a lot more debris and some food. It might have an issue with air escape when you're speaking, so they might have problems phonating. So you really want, it's a delicate balance by getting it to the tissue where it's closed enough, where it's sealing it off, but they can also clean. That's the name of the game. Yes, and sometimes it takes time. So this material is really nice because it's easy to adjust. I think that's pretty close. I'm just gonna roll it in, Dave. You know what I'm saying? I'm gonna roll it back so there's not like a little lip.
Yeah.
But that's pretty close. You have to polish this thing. They put when the lab does this, they put like a glaze. They put a glaze on this. This is where I adjusted it, but it's got to be super smooth. They put a glaze on it. That's all. You know, they like paint like a glaze on it. But you can see where I adjusted. It's like whiter, and then here they have like that glaze, and I think it's they use a glaze. A lot of people use like a glaze called, it's like Pala glaze I believe it's a Kulzer product, and and then you light cure it. Yeah, so I gotta make this look nicer. You see? Hold on. You're right, Jack?
So do you have a...
See, that's better now. What's that?
Do you have a workflow in your mind about posing arch, crown and bridge, use zirconium, crown and bridge, use... nanoceramic.
That's good.
Denture teeth, use whatever you want. You know, like natural teeth, don't use zirconia.
Right.
Yeah.
There's different theories on all of it. So in an ideal world, it's nice to have like material opposing like material because they're gonna wear. However, when you do zirconia over zirconia, the big complaint is that you hear this like clanging and clacking because they're like, you're crashing to super rigid and non-forgiving. Close down. I think we're doing a little. It's blanching a little bit, but not nearly as much, right?
No,
just a little bit.
Right. So I'm going to take it out one more time, and I'm going to just make a little bit of an adjustment. Can I have that? How does that feel now, Joe?
Wait.
Close down for me. There you go.
Yeah.
All right, we got rid of the blanching.
He only talking to 15.
Yeah. Growing teeth side to side. Good. And open for me. And again, I'm not having him, and if you look at this with his occlusion, his anterior teeth are not in occlusion. Because if his anterior teeth were in occlusion, with the vertical that he has, bite down for me, I would have to either lengthen the teeth or I would close his vertical down, or I have to move the teeth in.
Right. But we opened them up.
No, yeah, I wanted to open them up because you don't want
Yeah.
Yeah.
We hate that.
a super vertical overlap when you have these type of prostheses.
Yeah.
So this is just, it's by design. It's not maybe what he would have if he had a fixed prosthesis or his natural teeth over
Right.
time.
Right.
But he's also class 2.
Right.
Skeletal class 2, which is,
Yeah,
I mean,
of course.
okay.
Yeah.
And so,
First class, first.
so people who are class 2, generally, unless they have the class 2 with the lower anterior teeth that are super erupted, their anterior teeth don't touch.
Right.
And so, you know, I mean, and I think a lot of clinicians would have closed him down so his anterior teeth touch. But
I just love how it sits on his palate, like nothing on the palate, very little.
yeah, and the way it sits against his tissue is great. That's to me what I.
That's a great view right here. The access holes are really in a good position.
Yeah. Oh yeah. Oh yeah. I generally have the patient do. I'll put it in with clip. Bring the patient back after a re-eval. Make sure everything's okay and they're functioning okay, and I don't have to, for whatever reason, make any modifications where I have to unscrew it. And then if everything is good, can I have a little more? If everything is good, I'll seal it at that point with composite. And the composite will bond to this material. But you technically don't have to. And if you were going to remove the prosthesis to clean it, because some clinicians do that, then I wouldn't put composite because you have to drill it out. I would I would put in the same material that I use. But the other thing is that when if you noticed before, I use different color Teflon tape. Because it's just easier for me to see it, and some of the different color Teflon tape is thicker, so it's, you know, I don't have to roll up a whole bunch like I just did now. But if you're going to go ahead and then cover back over the Teflon tape, you want to use a white Teflon tape where it's emerging from the tooth, because cosmetically, if you have a different color Teflon tape, it's going to shine through.
So what is that again? That we put
This material is called Clip. It's a Voco product.
Oh,
it's like an interim restorative material that's light cured, and it's like kind of like, it has the consistency of like a gummy bear after you cure it. But it's easy to remove. You can pick it out generally with like a scaler. And so, bite down for me. Open for me. Because you see where they are? All up.
To be honest with you,
Yeah.
actually, the like lip inside is a lot less. You
Yeah.
can feel with my tongue.
Yeah.
Yeah, it's less than the temporary. 'Cause the temporary,
Yeah.
we needed the bulk for the prostate.
I felt like a lot of food got stuck in, like up there when I was, just like, not that it was stuck, it was just like went up there, bro.
Yeah.
Yes.
Especially peanuts and stuff like that.
You like shelling peanuts? Like, yeah.
I love you.
You asked me what the maintenance protocol was.
Yes.
So my maintenance protocol, first of all, I never do anything all the time. So in general, for my fixed screw retain implant prostheses, I just have the patient make sure that they're practicing appropriate home care, go over that with the patient at delivery. And then I will see my patients at a minimum biannually, so my hygienist can clean the prosthesis. I do not remove the prosthesis, because if you remove the prosthesis, which is totally fine, it takes time, and ideally we need to replace the prosthetic screws, because we're going to torque the prosthetic screws to the manufacturer's recommended torque. And once you do that, technically now the screws are fatigued. So if you're going to remove it, you should really get new screws. And so unless you want the patient to incur a decent fee, and it's going to take up your time as the clinician to do it, because I'm not going to have my hygienist do that. I like to just keep it in the patient's mouth. Other times, what can also happen, and it happens rarely, but sometimes the framework of the prosthesis can distort. And sometimes when you take out some of these fixed restorations, you have a challenge of getting it back in because things have shifted and distorted. And there is nothing in the literature, at least that I've read even recently, that is recommending that the longevity of the prosthesis will increase or be more predictable if you remove the prosthesis for hygiene. It is nice to remove for hygiene. It's easier for everybody if you can do it, but think about the pros and cons to doing it, because if you take it out, again, you should replace the screws, and it's going to require time on the clinician's side.
It feels good, tight, should be no issue.
Yes, I don't need to expose the patient to additional radiation.
Gotcha.
It is
passive.
It's called passive fit, where we know that when I'm screwing it in, all screws are engaging, and I'm not getting resistance, because if it didn't fit, you would get some resistance.
Gotcha.
But also, what we did was we did our cast confirmation, and and the other thing with this system is that if you really want to check to make sure that everything is accurate, this cast that we made our final impression with, if you recall, with the dupe, will fit on the temporary. The temporary will screw right on here passively.
Right.
So that's it. I don't need to radiograph to see if everything's seated.
Right.
You might want to radiograph to see if your multi-unit abutments are seated, but that's different because the multi-unit abutments might not be seated, and I'm making it too ill-fitting. But whatever.
Gotcha.
That's that. Jack, how's that feeling, man?
Feels good.
Yeah.
Yep.
You think?
Ready to go. Have a steak
you'll
sandwich.
Peanuts with us?
Peanuts, a steak sandwich. And get popcorn with peanut butter.
All right, Jack.
Looks good.
Yeah, okay.
We'll see. We'll get. I just take those ones you take and let me take home. I'll put them right in.
That looks good, though. That does look good, though. Yeah.